education out. Is this true?
No, not in this group.
Good morning, everybody online. Good morning, everybody. It's 9 o'clock. We're gonna get started. Our first presenter is going to be Kate and Brooke. Actually, I'll let them come and introduce themselves, so thanks.
I'm Kate. I'm the catalog manager. I presented last time we were here, these many cases. I kind of was an interim testing coordinator, just kind of filling the gap between Will. And I'm so happy to introduce Brooke Thomas, as our new chest pain coordinator. She came to us from regional ICU, so she's got lots of experience with cardiac patients, and she's very detail oriented. So we're really happy on our team. She will be sending out timelines and some feedback to your services as you bring them in. And she's going to present a patient today that early June. So going forward, if there's anything that you need from us, from Union, from the cardiac cardiovascular service line side of things, reach out to Brooke, and she'll be happy to connect you.
Okay. So this case is a patient that came in June 3rd. TransCare was dispatched out simply for a lip assist. This lady had fallen twice at home and just called the ambulance and said, I need help up. I might need to go to the ER. Once they arrived, they found out that she was pretty hypotensive. I believe her pressure was in the 70s and was very dizzy. So she was given a 500 cc bolus, and they went ahead and called ahead to the ED here and just said, hey, we've got this lady. She's fallen twice, hypotensive. Our ER activated a trauma 1 just because they didn't know the mechanism of fall, whether she had their head or anything like that. Once she arrived here, they found that, she really didn't have a traumatic fall, so they canceled the trauma 1. But during the provider's assessment, she mentioned how dizzy she was and, that she just really kind of leaned on the couch or whatever. But just in passing said, I also have a little bit of chest pain. But that was not her main complaint, and she didn't really allude to that. They went ahead and did an EKG. She was a STEMI. They did a heart cath. She had 100% LAD stenosis with successful stenting. She did get discharged on a life vest. Her EF was only 20%, so chances are she probably had this blockage for a while. She was given goal-driven medical therapy, and I think she went to a rehab for some weakness. So there's our numbers. From the time that you guys got to her till her balloon time, I believe was, I can't see the number of that. 94 minutes, which is well under our goal. I mean, that's 94 minutes we want, but even though she didn't present with chest pain, Florida balloon was 75 minutes. So because of your guys' quick action, you identified that she,
Code blue, 2
they were able to
Code blue, 2
so there's her
EC4.
EKG, as you can see, it's pretty clear. She was an anterior infarct. There's a blockage. There's the stent placement, it's totally included. And there's happy coronary stenosis intervention. So just to point out again that you guys did a great job with early recognition of, she was basically an early cardiogenic shock. And your ability to identify that and alert the ED was able to expedite services. So we really appreciate everything you guys do. You're the first one on the scene, and you're kind of our first eyes and ears. So keep up the good work, and we really appreciate everything you do. Thank you.
You have any questions for Brooke? Thank you, Brooke.
Thank you, guys.
Beth is up next with a couple stroke reports, one from Clinton and one from Charlotte.
Good morning, everyone. Technology, yeah. This one's from Clinton Hospital. It was a 59-year-old female. She lived independently. Her only current medication was atorvastatin for her high cholesterol, but she was experiencing a very high stress level and was on an anxiety medicine, but it was never specified what she was on. She was a smoker. It's her past medical history. EMS was dispatched to a private residence for an unknown medical. Upon arrival, they found the patient was lying on the floor. She had slurred speech and some aphasia. And the patient just grabbed her right arm, and the only thing she could get out was stroke. She was exhibiting severe right-sided weakness and facial droop. Daughter was on site, said the patient was fine about 9 a.m., but called her at 11:08 with slurred speech. Her finger stick glucose was 98, and her Glasgow coma scale was 15. Sinus rhythm, BP was 144/75, pulse 86, SAT was 97 on Romare, and you got an IV started into the left AC. Her Cincinnati pre-hospital stroke scale was positive. Vein was positive for aphasia and right-sided weakness, and a stroke alert was called to Clinton ER via the iHeart at 11:41. The run times, EMS was notified 11:26, dispatched 11:26, en route 27, on scene at 28, and outpatient at 29. Very fast response time. They departed at 11:41, ER at 24, they transferred the patient at 11:48. This patient followed our protocols at Clinton. She went directly to CT per EMS cart. They established her last known well at 08:50. It probably happened closer to the time she called her daughter, but that was the last time the daughter knew for sure that she was fine. My age was 12. Had a CT stroke, was all at 11:48. It was negative for a bleed. Teleneuro was consulted and they advised T&K, and it was administered at 12:20, which was a 33-minute door to needle time. So good job for Clinton. They went ahead and did a CTA at 11:37, and it was inclusion of the left internal carotid artery from its origin due to calcified plaques. It did have some distal flow interrupted to the M2 segment. So you think where your MCA territory is, it's here. So it was the second segment off the MCA territory. So it's usually a large stroke when you have MCA stroke. Patient was transferred to IU for interventional radiology. Was thrown out at 13:32. She ended up being an ER to ER transfer to Methodist because there were no beds available. But it's, what we could do at that time. And there was no patient follow-up received from IU. I really don't know what happened to her. But usually I can see when they come back and go through mid-rehab, how they did. She only had outpatient stuff scheduled, so she must have done very well. So good case. I will say is the strengths of the opportunities of this one. There was really good documentation. There was a great narrative in there by West Park County EMS, and they did a really great narrative of the patient condition. So good job to them. The second case is one from Union. It's a sad, it's a very good case. This was a 56-year-old female. She was independent, had a long history, as you can see. She had ICD, CHF, COPD, CID, hypertension, hyperlipidemia, and she was diabetic. She had a history of a large stroke in 2019 with no deficits. Multiple home medications, and one that she was on was Plavix. EMS and engine was dispatched to a private residence for a fall. When they got there, they found the patient was lying on the floor of her house. She had been outside and had drugged herself in the house. She was incontinent of urine at that time. Her mother was on scene and said the patient was normal until the fall. She was out walking in her yard, fell. She was transferred to the cot and taken directly to the ambulance for assessment. She was exhibiting extreme left-sided weakness and right-side neglect. Patient vomited and was incontinent of bowel within the ambulance. Zofran was given. Cardiac rhythm, sinus rhythm with a right bundle branch block. Her GCS was 15. Pressure was 174/90. Pressure was 12. O2 sat 97 on Romare. Got an 18 gauge started to her right AC. The Cincinnati pre-hospital scale was positive. Her vein was positive for weakness and neglect. Stroke alert was called to Union ER via iHeart while en route, and handoff was given to the ER physician. Patient went directly, EMS was notified at 13:33, dispatched 13:35, en route at 36, on scene at 39, and outpatient at 50. So I don't know. I think that was supposed to be at 40, please excuse me. EMS depart at 13:58, arrived at ER at 14:06, and patient transferred at 14:14. She went directly from card to CT1. Her last known well was established at 13:18. Time she got to the hospital, her NIH was 13, so she's going to be a pretty big stroke at that time. CT stroke at 14:28 was negative for a bleed, but it did so at encephalomatia in the right front and right parietal lobes from her previous stroke. And what that means that she had a right parietal and a right frontal stroke before. She had no deficits from, but her brain material was thin there and a lot of damage, but she just didn't have the deficits. So she had a lot of damaged brain already to start with. Teleneuro was consulted and they did advise T&K, and her door to needle time was 28 minutes. CTA was completed at 15:30, which showed a chronic occlusion of the right internal artery, carotid artery. M1 and M2 were occluded. So almost all MCA was occluded at that time. They did have to start a nicardipine drip because her pressure went high. And IR at St. Vincent's stated she was not a thrombectomy candidate due to the chronic occlusion of her internal carotid. She was admitted at ICU, did not have a good course after that. CT of the head was repeated the next day and was positive for right frontal, parietal, and temporal lobe with effacement of the right internal, right lateral ventricle. So that stroke is evolving and growing. She did have a small hemorrhagic conversion. And the MRI showed a continuing evolving stroke, which now includes the right basal ganglia and the lateral thalamus. And then she had an additional infarct involving her left frontal lobe. So she's infarcted her left frontal and most of her right hemisphere. Not much we can do with that, unfortunately. So we did consult neurosurgery here, and they wanted her, started her on hypertonic saline. They did everything for this poor lady. And neurosurgery said really the only thing we can do is maybe release some of that pressure with Craney. So she was transferred to St. Vincent's via ground transport. When she left here, she was on room air, which is surprising with that much of an infarct. They didn't go ahead and tube her. I'm surprised they didn't to protect that airway. She arrived at her destination about 90 minutes later and required immediate intubation in the ER. She just could not maintain her airway. She was diaphoretic and she was comatose. The CT was repeated and showed an infarct to the entire left hemisphere, and the one on the left, the entire right hemisphere, and the one on the left was evolving. Family signed it, and the patient passed. It was a very good case, a very sad case, but extremely good documentation by EMS. Even though she didn't present with terrible symptoms when EMS saw her time she got here, she deteriorated quickly. On a side note, on the image, I went back and looked at her imaging from 2019. She had greater than a 50% stenosis of the internal carotid at that time and chose not to do any treatment. So it continued to include it, and here we are. So really pretty sad case. But that's it. Thank you. Anybody have any questions about anything?
Thanks, Beth.
Thank you.
Tina, you ready? Next up is going to be Tina with our trauma report. Who's here? Yeah. We'll be gone and I'm here.
Get a walk in.
The first case, a 79-year-old male, is a fall from a ladder. 911 call came in at 12:51, dispatched and en route 12:51, on the scene 13:02, departed at 13:21, and at Union ER at 13:35. Times dispatched to en route was 11 minutes. Dispatch and dispatch to en route to arrival was 11 minutes. On scene to departure was 19 minutes, to arrival at ER, 14 minutes, total call time, 44 minutes. So they were dispatched to a patient's residence for a fall from a ladder about 15 feet. On arrival, they found the patient sitting on upright in the care of the fire department with the C color on. He was on an extension ladder propped against a flagpole. The pole started moving, caused him to fall about 12 feet, it said, to the ground, landing on the right side. He was alert and oriented, no loss of consciousness. Didn't hit his head, but he was uncommuted. Pain in his right ribs, radiating to the right pectoral region. Pelvis was stable, mild pain on palpitation of the right hip. Vitals were pretty stable. DCS was 15. He was loaded onto the cart, started an IV. He declined pain medicine at that time. He had him on the monitor with an atrial fib. And they called an IHERN and transported him to the ER. So the pre-arrival, so fall from the ladder about 12 feet, right rib and sternal pain, right foot pain, no loss of consciousness. He was uncommuted. He was a trauma activation level 2. This page at 1333. ER physician was notified 1340. Physician was at the bedside at 1345. He was a fall off the ladder while installing the flagpole. He was complaining of right rib pain, positional sternal pain, some hip pain with movement, but not palpation. Was not endorsing pain until just right before arrival. On arrival, he was on a backboard with the C color. So he met criteria for fall greater than 10 feet for an adult and considerable risk factor in patients 65 or older because he was uncommuted. So on arrival at ER, 1341, vitals were still pretty stable. Sat with 96, they put him on 2 liters. Had a history of hypertension, arrhythmia, sleep apnea, pulmonary hypertension, PVD, and heart failure. He did have some bruising on his right anterior chest with tenderness. Had a tiny hematoma with any bleeding. Mild tenderness the right upper quadrant, and his belly was soft. Placed on O2 because they had concern for pneumothorax. Started the second IV. FAST was slightly positive. Don't know what that means. Either it is or it isn't. You know,
I like being a little bit
I
pregnant.
might have to say that,
It's
you
either
know.
positive or.
Yeah,
There's no slightly positive
Yeah,
or bad.
so-
Could possibly be.
Anyhow, they did put on a pelvic binder, which is good. Meds given, they gave him a liter of saline, antibiotics, pain meds, reversal agents. The CT of the imaging, the CT of the spine showed he had displaced transverse fracture, mildly displaced. Of the T1 transverse process, minimally displaced transverse fracture, right T3 spinous process, displaced fracture, right medial 4th rib. CT of the head was negative. CT of the abdomen, he had minimally displaced fracture of the right clavicle. Mildly displaced fracture of the right 2nd through 4th ribs and lateral right 6th through 10th ribs. Had some patchy ground glass densities and belt lines from pulmonary contusion probably. Comminuted fracture of the right iliac wing extended to the right acetabulum. Comminuted fracture of the right acetabulum involving the anterior and posterior walls. Mildly displaced fracture of the right superior and inferior pubic rami extending into the pubic symphysis. And then he had a small amount of perihepatic fluid, decreased attenuation of the medial right hepatic lobe up to 3.5 centimeters. Laceration couldn't be ruled out as labs. Were too awful bad. His INR was 1.53, so he wasn't really even therapeutic. Sodium was 135, potassium 3.2. Stroke was up a little bit. Lactic was 2.4 and then 2.8. They tightened screen as alcohol was negative. The final diagnosis was spinal fracture T3, T4, pelvic fracture, hematoma, liver laceration, rib fractures, and pulmonary contusion. So they did call trauma at 14:56 after the FAST was positive, and they recommended transfer to IU. They spoke with IU and got acceptance for the transfer. They gave him 1 unit of pack cells prior to his transfer, and they sent him to IU Methodist by ambulance at 17:22. So when we do reviews for these patients, it starts from the time the 911 call initially comes in, all the way through to where the patient leaves, whether they get transferred, they go home, or if they get admitted, we still follow them. But not only are we looking to see what is done when it's done, but there are trauma guidelines that we follow in the American College of Surgeons to make sure that we are following best practice guidelines for these patients. So they have the best outcomes. And these are the guidelines that he met for rib fractures, transfer out to make sure that it's timely and it's appropriate. Blunt abdominal traumas, cervical spine precautions and clearance, and geriatric trauma, which is literally a book on its own. So that's kind of what we look at with all those patients. Anybody have any comments, questions?
It's too bad they did, ETOH was negative. He'd have been better off, I think.
I know, right? Probably wouldn't have got hurt at all.
So this is one of those cases that we should have had out the door in 120 minutes. Obviously, we blew that timeline.
Yeah.
There was a little delay in the doctor seeing them. I don't know what that was all about.
Yeah.
Quite a bit delay actually in our doctor seeing them. This is a good example of why we inside the hospital really should think about that. That probably teetered on a level 1 even before you knew all the injuries, which would have expedited testing, expedited transfer and all that. Scene time was a little long. We just talked about that. It was 19 minutes. So, you know, that definitely would have been a 10-minute case, but I don't know where he was at or, I mean, he was obviously outside. I assume he was outside, so.
He was installing the flagpole in his liver.
Yeah.
Yeah.
There was a lot of opportunities in that one.
Anything else? All right, the second case is a gentleman that is well known to us in the ER and probably EMS. He's a 31-year-old male, is a fall. 911 call came in at 23:57, dispatched at 23:57 en route 23:59. On the scene at 4 after midnight, and part of the scene at 00:14 and Union ER at 0:22. So called dispatch was 0, dispatched en route was 2 minutes, en route to arrival was 5. They were on the scene for 10 minutes. Departure to ER was 8 minutes and total call time was 25 minutes. So they were dispatched for a 31-year-old male who had fallen. On arrival, the patient was on the ground. PD was present with the patient. Here's your sign. Patient stated he fell off the porch, hit his head, no thinners. Positive loss of consciousness. He had dried blood in his nose and mouth. Obvious injuries to his face. He had swelling to his right eye and a 1-inch laceration under his left eye. Able to ambulate to the ambulance. DCS was 15. Pressure 150/90. Heart rate 78 or 75. Press 18. 98% on room air. At IV, they started a saline log, put on a C color, called an IHERN, and transported him to Union ER. So level 2 was called by Dr. Myers. And it was activated at 00:28. He arrived at 00:29. Physician was bedside a minute later. He was a little tacky by then. It was 108. The blood pressure, he was hypertensive, 141 over 111, 94% on room air. Now, per police, the patient was involved in physical alteration with someone else and was punched several times in the face. PD was called due to the dispute. But patient sticking to the story, he fell off the porch in low height and injured his face. Pain to face and head, he had the C color was secure. Multiple abrasions with dried blood all over his face. Mild tenderness to the scalp, but there were no lacerations. Slight posterior tenderness, bilateral paraspinal muscles. They gave him morphine and Zofran. Now, if you look at the criteria, specific criteria, he didn't really meet, but the physician or the charge nurse always has discretion at calling it. And something that Dr. Myers heard kicked in his physician spidey senses, and he was like, yeah, this is probably an activation. And he was right. They didn't do any labs, which was a little surprising. Imaging, CT of the spine, no acute findings. CT of the head was negative. There's maxillofacial CT. He had acute fractures of the right mandible body, left mandible, ribs at the angle. Complex comminuted left-sided facial fracture. One or more combination of left-sided LaFort type 2 and 3. Acute fractures to the left maxillary, central incisor, and a second bicuspid. So he got whooped.
You made someone
Yeah.
mad.
He does tend to
That
do
porch
that.
was intense.
So his diagnosis was assault, facial fracture, fracture of the right mandible, two fracture, LaFort, 3 fracture, and 2 fractures. So the doctor said he would require transfer to a higher level of care, which was correct. And he transferred him to IU Methodist via ambulance. So these are the LaFort fractures. So he had LaFort 2 and 3. And there's some of the things that you look for. Complications with LaFort fractures can be pretty nasty. There's a lot of complications with them. They have a high risk of infection and all, but the biggest thing are with airway obstruction, especially the higher the fracture. CFS leak, or CSF, sorry. Visual disturbances that can be permanent, and other injuries. A lot of times if you hit somebody in the face hard enough, or they hit their face hard enough, more than likely they're going to have other injuries too, so you need to look for those. Anything on that? I think it's a good call on Dr. Myers to call it.
Yeah.
Yeah. That's all I got.
Thank you, Dina.
Thank you.
Might as well. It was something repetitive.
Yes.
If you next up is gonna be Megan Ellis, I'll let her introduce herself.
Hope they didn't shut up. I got scared.
I would just introduce.
Excuse me. Oh, here.
Yeah.
Okay.
All right, good morning, guys. My name's Megan Ellis. I'm a nurse by background. I've been a nurse for about 14 years. I worked locally here for 5 years, worked at Methodist for 2 years, and then I have been transporting patients with Lifeline for the last 7 years. I am here to talk to you today about a case that we took out of local area a couple months back. I thought it was a good case. On-scene agency did a great job, and then neurotrauma is related to the case. That's dead giveaway here. But couple disclosures I have no financial interest to anything that we're going to talk about. I think that's fine up there. I am being paid to be here today. I have bills, all of those things. So I am being paid to be here, but anything that we talk about today in this, any medical devices or anything like that, I'm not affiliated with any of them. This presentation does contain some confidential information. I've tried to scrub it from as much PHI as possible, but please don't go outside of this meeting and share any information that we talk about. And then any information that I present to you is for educational purposes only. It's not being presented as professional advice. Please always follow your local protocols and or any kind of working agency protocols. So let's I don't think I ever have anything kind of down here in this corner. So let's talk about the case. So local agency gets a call. It's a nice afternoon. It's 75 degrees and sunny. And they get called to the scene of a motorcycle crash. So, before you get to scene, single vehicle, motorcycle lost control and left the roadway. What are you guys kind of preparing for on the way? I have much more involvement from the crowd on mine, so. Yeah, and so especially with a motorcycle, like questions that I'm asking myself, like, do I think that they had a helmet on? Did I find out that they had a helmet or not? And I don't know if that's information that you guys get from local dispatch when you guys are headed out. Probably just if, like, dispatch told you that, if a bystander reported that in the initial call. So the area where this accident happened, speed limit's about 20 to 30. That's another question that I'm gonna ask. Do I think that they were probably going 20 to 30 miles per hour on a beautiful sunny afternoon? What's the road like? Is it gravel? Is it paved, etc.? What caused them to leave the roadway on their own? So local EMS arrives, they see a gentleman who denies loss of consciousness, was not wearing a helmet, but he is complaining of pain to left shoulder and posterior neck. And upon their assessment, he has no sensation or movement from about mid-chest down. They do their rapid trauma assessment, don't see any external signs of hemorrhage, but they rapidly assess that, something's going on with them. So what are immediate things that you guys are considering? Yeah, spinal cord injury, right? And so they did a really great job quickly placing this guy in full C-spine precautions. And I know that there's a lot of controversy right now about full C-spine precautions, right? Do we collar people? Do we put them on long spine boards? Do we put head blocks on people? A lot of patients, I would say, I'm a little iffy about. This patient, I'd say probably so, especially if you're gonna have to drag him through the grass and get him in the back of an ambulance and move him to another cot and have to manipulate this patient a lot. This is the patient I'm gonna probably opt to put on a long spine board. But do what we learned in EMT school, and I just went through EMT school about a year and a half ago, have the board, right? Do not make these people uncomfortable. Have your board, make it as comfortable to have them on them. Make sure your C-collar is appropriately fitting. If you don't have a C-collar that's going to appropriately fit somebody, opt out of a C-collar and just do head blocks. Make sure that they can appropriately be placed in these things. EMS was really great about establishing 2 large bore IVs, calling for immediate air transport, and then starting a little fluid bolus. This patient, as soon as they popped him on their monitor, had an initial hypotensive episode. And so to preemptively make sure that they didn't remain hypotensive or have another hypotensive episode, they started a small fluid bolus. So let's look here in this middle section, we've got some vital signs. And so let's kind of pop through these. So if I am concerned about a trauma patient, I don't know that I'm expecting to see a heart rate of 62 on my trauma patient. Low blood pressure, sure. I'm concerned about bleeding. Hypertension isn't crazy, but hypotension and a low heart rate are not 2 things that I think go together for a trauma patient if I'm thinking about hemorrhagic shock. So this is already kind of like lighting off some fireworks for me. Anybody else in the room? Yeah, so this is already kind of triggering some things for me, along with patient presentation. So respiratory rate, I'm not super jazzed about. I'm not thinking that's too crazy. The pulse ox, when we got in the back of the ambulance, had already been pulled off their finger. So we just waited until we could pop one on ours, took their word for it, and unfortunately, I don't remember what it was. But pupils were pearl, GCS was 15. Patient was alert and oriented and complaining of 8 out of 10 pain to that left shoulder and posterior neck. Like I said, they started a fluid bolus for us. And then we entered the back of the ambulance and the medic had fentanyl and Zofran in their hands. We were just really fast to scene. And so we said, hey, can you hold on that for just a minute? We want to go ahead and make sure we get our assessment done before we get fentanyl and maybe tank of pressure again, get them on our monitor. So we did our quick assessment. It was very similar to theirs. No external signs of bleeding. Breath sounds were good. And for this patient, we want to really assess, in my opinion, that they have good maintenance of their airway. They don't have any problems swallowing or breathing, because I am already really concerned about C-spine injury. And given that he has no feeling from nip line down, where is the C-spine injury? How high does this extend up? He's saying he's moving his arms all around, but can he feel underneath his arms? Is that perfect? Does he have full dexterity? And that's not something I'm gonna get really nitty gritty in the back of an ambulance. So I wanna make sure that he can have full control of his airway and of his breathing during my care of this patient. Lung sounds were good. He was a little diminished in his bases, had great cap refill, good strong pulses, pelvis was stable. And then the disability, made sure he was still about xiphoid process down, had no sensation. And I know it's not everybody's favorite thing to do, but if I am concerned about a C-spine injury, we need to be checking for a priapism and probably rectal tone. We did defer rectal tone on this patient because he was already secured to the backboard. But if you are securing a patient to the backboard and log rolling them, when you have them log roll to put them on a backboard or to check their C-spine, I'm not telling you have to do like the Methodist or the Ashkenazi handshake, okay? But you can say, hey, can you squeeze your butt cheeks together for me? That's enough to say, hey, do you have control of that area of your body, all right? And then our vital signs were okay. We thought that assessment looked good. And so EMS on scene went ahead and we witnessed them giving Zofran and fentanyl. Got him loaded up, placed him on a couple liters of oxygen on the way to the aircraft, hot loaded him. Hearing protection was a little iffy with the head blocks. Our headset doesn't fit with the big foam rollers. So we just patted him with some towels, got on our way. He continued to complain of some shoulder pain. So we gave him another dose of fentanyl, increased oxygen on the way, which isn't crazy, getting some narcotics and going to altitude, laying flat, all of the things. And then continued treatments en route. Even though he has a GCS of 15, he has a history of diabetes and hadn't eaten that day. So we went ahead and checked a finger stick glucose on him. It was fine. It was 164. And then just continued to reassess neurostatus. And so we'll talk a little bit later about how often we're doing that, like a GCS and maybe things like that. But for us, for our protocol, we're going to do that probably about every 15 minutes at a minimum, or at a maximum, probably a little bit more often than that for a patient like this, or anytime we have a change. Vital signs really trended pretty good en route. Blood pressures were great. Our MAPs got no lower than 66. And SATs, like I said, he hit 90 before we placed him on oxygen, and so we increased it. His highest shock index score for us was 1. So I was pleased with that. I think he probably, we had kind of 1 lowish pressure. And so we kind of restarted those fluids and got radio report called to Methodist. So once we got there, we got him unloaded from the aircraft, transported down to the ER. He was activated as a level 1 trauma and received in the ER by ER and trauma staff. Got him moved over on the long spine board. Again, this is the reason why we kept him on it. So no manipulation of the spine or the neck. And they immediately started working on him. First set of vitals were pretty stable. Popped 1 hypertensive one, but it was when they were really manipulating him and kind of bugging him. And then he had a negative fast and negative rectal tone. And so that again is kind of like reassuring me that what I think is going on with my patient. Determined after they kind of triaged him that he was stable enough to go to CAT scan. He went down to CAT scan, and when they moved him over to the table, he had 1 kind of labile blood pressure. Considered starting a small fluid bolus, maybe grabbing a pressor. But by the time they went to get it, he was already back up to a normal blood pressure. At this point, we left to go clean our cot. We were done being nosy. Cleaned our cot, made some copies of paperwork, and saw him roll back down to his room where he was going to get a central line and neurosurge consulted. So then we left for the day, and I asked for follow-up on this gentleman. And he ended up with some pretty significant injuries. So this guy had a posterior left subarachnoid hemorrhage, and so that's bleeding in that subarachnoid space. And then left vertebral artery injuries, and so this is a blunt cerebral vessel injury. And this happens, these are graded out a little bit differently, and so this can be kind of like a pseudoaneurysm. This is probably going to be from that hyperflexion injury from crashing his motorcycle. He had acute traumatic spondylothiasis of C6 over C7, and so what happens here is C6 over C7, C6 slipped forward over C7 and caused that injury to the spinal cord. And that's where we saw the most damage for this patient. Fracture to the posterior inferior C6, distracted fracture of the C6 spinous process. And so when we say distracted fracture, that means that it's not just a crack in the bone. Where that fracture is, it is actually pulled apart in that spine, in that vertebra. And then a mildly distracted fracture of the C5. And so that is just not pulled apart as much. A hemothorax on the left, bilateral pneumothoraces. Neither one of these required immediate chest tube placement. Some rib fractures on both the right and the left. A T6 fracture, a T7 fracture, a T8 transverse process fracture, a manubrium fracture. And so if we all remember where the manubrium is, that's the upper part of our sternum. Bilateral clavicle fractures, and then L1 through 3 transverse process fractures. So this gentleman did a great job at Humpty Dumptying himself. So immediate treatments that this gentleman got, like I said, in the ER, he immediately got a central line placed, got some stabilizing treatments. I did have some. And then he went to the OR that day from the ER. He ended up getting a couple laminectomies, a posterior spinal fusion, and then after he had been in the OR, they took him down for a repeat just to make sure that subarachnoid had not grown at all. A little while later, they took him for an MRI to just kind of see what blood flow was looking like, considering his significant spinal cord injury. And unfortunately, he did have a posterior circulation stroke to the cerebellum and the occipital areas. And so that is unfortunate. He remained intubated for about 4 days post this initial big surgery. And during that intubation, he was on a pressor and then weaned off of a pressor. He'd been placed on tube feeds, obviously, because he was intubated. And given the fact that we weren't sure how he was going to be able to deal with like speech and things like that, swallowing, given the nature of his injury. With all the chest injuries that he had, those pneumos, hemos, all the rib fractures, they treated aggressively with pain, pulmonary hygiene. On about the 3rd day of admission, he did require a chest tube placement on the left, just because effusions were growing and they were concerned that if we didn't address it then, it was going to become a bigger problem later. He ended up getting extubated and titrated down on high flow nasal cannula, which is awesome. But after he was extubated, he was able to say, hey, my left clavicle still really hurts, which I'm glad that he was able to tell them that, because I think that his recovery is going to be very involved with upper extremities. And so they went in and internally fixated that so that he would have the best chance of being able to do as much rehab as possible. And so on the 3rd, when he got discharged to RHI, he was being able to do tricep push-ups on the right. On the left was delayed because of the recent surgery, but I think that it's wonderful that they were able to retain as much upper extremity movement as they could, given the C7 injury. Any questions about that case or treatment that you might do? Or I think that sending agency did amazing, recognizing that this was a really serious neurosurge patient. They were going to need long-term follow-up care and getting them to a facility where an area where that was going to be available for them. So neuro review. Again, I'm going to talk and ask you guys to talk back to me as far as so. Neurological injury. So what kind of, when I say neurotrauma, what kind of injuries are you guys thinking about?
Brain bleeds.
Yeah, so TBIs, head bleeds, right? What else? We talked about it.
Spinal.
Spinal cord injury. Oh, good job, Kyle. Yes, spinal cord injuries. Excellent. Anything else? We kind of also alluded to it. It's related to these things.
Well, he had a stroke.
Stroke, yes.
Trauma.
And then like shock, neurogenic shock is related to both of those things. So TBIs, when we talk about TBIs, there's all kinds of TBIs, right? You can have a subdural, a subarachnoid, you can have DAI, you can have all of these things. Same with spinal cord injuries. It all depends on where your injury is. You can have a cervical injury, a thoracic injury, lumbar injury, etc. I don't think it is so important when you roll up on scene to be like, I think they have a subdural, right? Like, I don't think that you need to roll up on scene and be like, I'm diagnosing this head bleed as this. That's not super important. Now, what I think is important is to be able to go on scene, because you guys are all great and smart, to say, I think that this mechanism of injury and this patient presentation is indicating to me that they could have head bleed or they could have a spinal cord injury, right? And so I need to take them to a hospital that has neurosurge today, right? Like, that's a great use of your skills. So first, we're gonna talk about TBIs and different kinds of TBIs we can have. So we're gonna start at the top here and kind of work our way around like a clock. So a contusion, I want you to think just like a contusion anywhere on your body. Okay, little tiny microhemorrhages, they often occur in the gyri, the little lumpy bumpy parts. Why? Because they stick out. Okay, they're the most protruding parts of your brain. That's where it's going to occur the most. But they often occur also the temporal and frontal lobes. Okay. Now, I don't want you to be like, a bruise, it's not that big of a deal. It's in your brain, it's a big deal. There's blood in your brain where it's not supposed to be. It is something to be worried about. Now, is it as bad as all the other ones? Maybe not, but it is still blood in your brain where it's not supposed to be. So, but just so you're like, oh, I've heard of this, now I know. So a subdural, moving on around, literally, if we look at the word, under the dura, right? So this is blood under the dura. The dura is a really thick layer of our brain, of the covering of our brain. So when we have blood here, often we see a nice smooth edge. And I'm telling you about these in case you get involved in interfacility transport, or you see a patient who's getting transported and you see their head CT and you're like, oh, that makes sense to me. So subdural, this is out here, you're gonna have a smooth line with these head bleeds. DAI. So DAI has always kind of bewildered me. Always been like, gosh, like we always talk about DAI. I just don't get it. To me, the best way to explain this. So this is usually like a very diffuse, large, reaching injury. It's from shearing, acceleration, deceleration, the white matter and gray matter kind of move back and forth across each other. And I want you to think about a light bulb and the filament at the end of a light bulb. And if you shake that light bulb, that filament's gonna break, right? So the axons on your neuron, when you shake the brain like that, that axon breaks and you can't put that back together. So when people get these injuries and they're widespread injuries and there's bleeding there, really poor prognosis because we can't go in and put these axons back together on all of these. The subarachnoids, this is bleeding between the subarachnoid space or the subarachnoid membrane and the pia mater. And these are both really thin layers. And so we see that we can see many more crevices of the brain because they're so thin, we can fill in more spaces. And then the epidural bleed, to me, this is a really scary one, just because of how they present and how they can kind of end up for us. But we often see this on the lateral to coronal suture when we have injury there. So if you think about a headband going around your head, when we see injuries or head strikes in that area. So, all right. So specific symptoms or things that come up with all of these kinds of head bleeds, we're only going to talk about 3 of them because they're the 3 ones that we see most often in the field. A subdural, they're going to have altered mental status and a suggestive mechanism of injury. I say suggestive mechanism of injury, they will have hit their head, but I want you to know that a subdural can be a slow bleed. And so they could have hit their head last night and have a subdural today. An epidural, like I said, they're going to have an injury in that area we talked about. They're going to have an initial loss of consciousness, a period of lucidity, and then a rapid decline. And so we always want to be anticipating the rapid decline. I think that's why they make me uncomfortable because it's like you're waiting for the other shoe to drop always. And then subarachnoid bleed, they're going to have horrible, horrible head pain, neck pain and stiffness, and then often they will have intractable nausea and vomiting as well. We kind of already talked about some of these on the left side, but I want you to know how many of these are late signs. So everything from about nausea and vomiting down, or I'm sorry, nausea and vomiting up are early signs, everything below that are late signs. So bradycardia is a late sign of increasing ICP. When our ICP increases initially, we get tachycardic. It is a sympathetic response to increasing ICP in our brain. And our body wants to overcome that blood in our brain to get a blood pressure or a cerebral perfusion pressure past it. And so we increase our heart rate to get past that. And so we'll see an initial tachycardia on these patients, and that's what should clue you into, hey, I think that they have increased ICP, I need to start working on something. Once they get bradycardic, we are already a little bit late to the party and we need to start working harder. All of the other things, I'm not going to take you back to school, you already know those things are signs of increased ICP. On the right, we see signs of spinal cord injury. Again, I'm not going to take you back to school, but if we don't assess things like rectal tone and priapism, you can't document it, you don't know that it's there. All right? What I do want to make note of here is the widening pulse pressure. It is not just hypertension, it is widening pulse pressure. Okay. Dermatomes, do we remember these? Do you like get your, yeah, a little bit?
I'm thinking of like shingles.
Oh, yeah, for sure, because it's all the same. Yep, it's all neurosystem, nervous system related. So yeah, if you like sweep the cobwebs out from the crevices of your brain, you've probably at least heard of dermatomes. I don't expect you to know C2 to L2, but there are 4 that I want you to remember, okay? Because these are the important ones. And so C4, T4, T10, and L1. Those are the big ones that I want you to remember after today. So C4, it's like a necklace at the top, right at your clavicles. C4, breathe no more. This nerve also controls your phrenic nerve. That's your diaphragm. So when we have an injury at C4, we really need to start being concerned about breathing on our own. T4 at the nip line is where we, like any injury between T1 and L2, our sympathetic nerves exit. And so we can start having some associated bradycardia, vasodilation, things like that in that area. And so T4 is just the easy kind of like midway marker for us. T10, the belly button, the 0 is the belly button there. And this is again, just a little bit lower, but still in that area of T1 to L2. And it's just kind of saying like, hey, we're still in this area. We'd still be having bradycardia, a decreased sympathetic response, but it's going to be a little less pronounced. And then L1, lifeguard, and it's going to be, lifeguard is to help you remember like the top of a bathing suit line. And it is just again saying, hey, if you have an injury here, you could still be having some of that sympathetic blunting, but it's not going to be as aggressive as with the other ones. GCS scoring. We live by it, we die by it. We hate it, we love it. We can do it in our sleep at 2 a.m. I'm here to break the stigma and say, like in the moment when have lizard brain because we're looking at somebody dying, maybe we don't have to do a GCS, okay? We could say an AFPU and move on with our day for just a moment, okay? GCSs are amazing for super sick trauma patients, especially neuro patients, but when you have the time, okay? When you have the time to go through and go, yeah, I've got all of these things and I can add up the numbers because all the time my brain doesn't work to go this, these numbers. Also, it does not work unless you report it out appropriately because my GCS of 9, that is E2, V2, M5, is going to be different than Heather's GCS of 9 if she doesn't report it out that way to me. I don't know that her GCS of 9 is the same as my GCS of 9. But my AVPU score of P, well, gosh darn it, it's about the same as an AVPU score of P. It cannot be any different, right? Has to be the same. So if we're doing a GCS, how often are we doing a GCS? This is again where you guys talk to me.
15 minutes?
Yeah, I would say every 15 minutes during transport or with a change in condition. And then at least when you get to them and when you drop them off, okay? Are you doing it that often? Right, yeah, right? Everybody's like, not really. We probably like that word. Huh? Yeah, right? Thanks, Kyle, my boss. But to be honest, a GCS is not like, I think that we think that this is like an NIH stroke scale and it's gonna take us 15 minutes to do this. It is as simple as going, hey Miranda, do you know what day it is? Give me a thumbs up. Okay, you did a GCS. Done. Like it does not take that long, but I think that we think it's gonna be really involved. And on some patients, it is. And on those patients, we probably know what their GCS is already. It's not changed, it's the same. Okay, so when I say AVPU, just as a refresher, just to make sure that we know it, and again, please follow your local protocols and your, like your agency protocols. But just, I'm putting this up here as a little refresher in case you ever see these and you're like, I've never heard of these before. So AVPU is on the left, alert, responsive to verbal, painful, or unresponsive, and then a simplified motor score can go along with those, especially for a neuro patient. They can obey commands localized to pain or withdraw to pain or worse. And these two things together can kind of shortcut that GCS in a pinch if you are really taxed because you're the only provider in the back of that ambulance trying to take care of a really sick patient. Finally, we're going to talk about shock. I'm not going to take you back to school. You guys are the masters of shock. You guys deal with this all the time. So hemorrhagic shock, what is it? Yeah, they've lost blood, right? These patients look crappy, but specifically they are tachycardic, have a low blood pressure because it's shock at this point, right? We want to keep them in a compensated state. So we don't want them to be thirsty. We don't want them to be anxious. We don't want them to do all those things. If they get to that point, bring them back from the brink, right? How do you treat hemorrhagic shock?
What?
Yeah, with blood. Do you guys carry blood? You don't. So you're going to treat them with crystalloid, preferably warm crystalloids, right? How much crystalloid do you give them?
Max a liter,
Okay,
have to systolic about 90.
right, systolic at 90, right? That's the goal. Systolic at 90, or if we think that they have a head bleed, because I've got to say it because I'm doing this neurotrauma, we want to take it up to 110. Okay, that's the goal, is a little bit higher because we got to perfuse around the blood that's in their brain. Okay, obstructive shock. What's obstructive shock? There's an obstruction. Okay, so there's an obstruction. Fix the obstruction, right? When we're talking about trauma, obstructive shock is probably two things. What are those two things? Yep, tension pneumo and tamponade, and it is specifically tension pneumo, not a simple pneumo, a tension pneumo. When it becomes tension, that's when it's an emergency, okay? So we fix those things and it fixes the patient. These patients look a little different than hemorrhagic shock, not wildly different, but a little different. They might be hypoxic, they're gonna have distended neck veins versus flat neck veins, and then they might have narrowing pulse pressure, all right? Narrowing pulse pressure. And then neurogenic shock, this is kind of the big heavy hitter I want to review today just because I feel like we don't see it a lot. And so when we see it, it's something that we're like, could it be? Is it? I don't know. So neurogenic shock, what is it?
Separation of the spinal cord.
Yeah, some kind of an injury to the spinal cord. Doesn't necessarily have to be a separation, but a large insult on the spinal cord. Enough to cause their body to go, ah, crap. Okay, so the spinal cord injury is so great that their sympathetic system has gone, can't do it, no more, I'm done. So they get bradycardic, they have vasodilation, and that's what causes this shock. Can you fix severe vasodilation with just fluids? Most often, no. We're gonna try with fluids first because that's what you got and you're giving that to a shock patient. It's a trauma patient. You're starting with fluids anyway. I don't want you to start going, I'm gonna give every trauma patient pressors because it might be neurogenic shock. Don't do that. We start with fluids anyway. So you're gonna start with fluids. When fluids don't do anything, you get no response. Then we're gonna go, I think it's maybe neurogenic shock, they're bradycardic. They have an injury that's indicating this. Let's go to a pressor. We have to give them that squeeze that they don't have intrinsically anymore. Okay? Does this make sense? Cool. All right, so hashing it out, neuroscience and symptoms, you guys were great at this. Dermatomes to know, C4, T4, T10, L1, okay? GCS scoring, we know it, we love it, we live by it. We're gonna do it all the time, but in a pinch, we could maybe do AVPU and SMS, maybe just for us to keep track because it's probably not in local protocols. And then shock, we just went over it. Anybody have any questions? I really appreciate your time this morning. I thank you for letting me be here. Cool, thank you so much.
Thank you very, very much. All right, guys, couple things before we're done for the day. One thing to mention, if you are due to have your research in September and you need signatures, get them from me before next Friday. 22nd on Friday, 22nd at noon, I am done. I will not answer the phone. I will not check emails. I'm going out of town, on a ship. I'm not doing anything. So if you need stuff before that, you need to get it to me before then. Outside of that, does anybody have anything they'd like to add? Nick, anything that we talked about that we need to bring up right now? Probably not so much. One thing, if you are a paramedic and you have not done the RSI written test, get it done. August 31st is the deadline. You only have to have 80%. Please do not take it 14 times to get the perfect score, because that's been happening and we don't need that. We just need 80% as a passing score. We've had people take it 4 or 5 times just so they could get it all right. So anyway, get it done. And then we're gonna start setting up the test outs with the medical directors for probably September and October, and trying to get that done, get it through the SIM center.
I'll ask him, but can we get medic students into that as well? Should I have them? Okay.
Yeah, you should have the QR code and the link to get into it, so yeah, they can take it. Yep.
PI meeting.
Yeah,
If you're a PI, you have to attend a mandatory meeting. Terre Fire Department is hosting one September 23rd, 1 to 4 p.m. at the training center, 2465 North Brown Avenue.
yeah, we were able to get Carrie on board for that, so that was kind of good. That's great, because the closest one was over an hour, was gonna be an hour away. So now we're gonna host it here, so if you're a primary instructor, please come and get your mandatory time in. And if you're not a primary instructor, but you'd like to know some of the updates, I imagine they would be perfectly set in. Anything else anybody got to mention? Kyle, Lori? Thanks, guys. Have a good day. Appreciate it.
Yeah, you the one taking it 14 times?
You know, smart enough.
3 times?
Well, he was fine. And then he tried to go with only one waffle after it goes to two, and I said, shove it in your mouth.
Had it all done.
Is that what they were? Okay. Yeah.
I sent that
He went
line from my
upstairs.
phone, so if you don't get it, let me
I got
know. Okay.
Supposed to. He comes right back down.